Pheochromocytoma. Dr. Attila Al-Riley. Pheochromocytoma catecholamine physiology/pathophysiology. Clinical presentation. Epidemiology. Signs and symptoms. Diagnosis. Biochemical. Localization. Management. Preoperative. Operative. Postoperative. Pregnancy. Catecholamine producing tumors. Neural crest. Sympathadrenal progenitor cell. Neuroblasts. Neuroblastoma. Chromaffin cell. Sympathetic ganglion cell. Intraadrenal extraadrenal. Pheochromocytoma. Ganglioneuroma. Catecholamine producing tumors. Pheochromocytoma. Paraganglioma, extraadrenal pheo. Originate in extraadrenal sympathetic chain/chromaffin tissue. Ganglioneuroma. Behave like paraganglioma biochemically. Catecholamine producing tumors. Neuroblastoma. Common malignancy in children, adrenal or sympathetic chain. Catecholamine humoral effects usually minor. Rapid growth and widespread metastasis. Some differentiate and spontaneously regress. Rx complex, surgery, XRT, chemotherapy. Cheodectoma. Carotid body, behave like paraganglioma biochemically. Glomus jugulare tumor. Intracranial branch of CN9 and 10. Behave like paraganglioma biochemically. Catecholamines metabolites tumor secretion, tyrosine L-dopa dopamine. Th. Mau, calmed. Tyrosine. L-dopa. Dopamine. Homovinilic acid. HVA. DBH. Calmed. Norepinephrine. Normetanephrine. PNMD. Mau. Epinephrine. Calmed. Metanephrine. Tumor secretion. Large pheo, more metabolites. Metabolized within tumor before release. Small pheo, more catecholamines. Sporadic pheo, NOPI greater than epi. Familial pheo, epi greater than NOPI. Paraganglioma, NOPI. Cheodectoma, glomus jugulare, NOPI. Ganglioneuroma, NOPI. Malignant pheo, dopamine, HVA. Neuroblastoma, dopamine, HVA. Mau. Vanilli-mandelic acid. VMA. PNMD, phenylethanolamine N-methyltransferase. Calmed, catechylomethyltransferase. Mau, monoamine oxidase. Adrenergic receptors alpha adrenergic receptors. 1. Vasoconstriction, intestinal relaxation, uterine contraction, pupillary dilation. 2. Presynaptic clonidine, platelet aggregation. Vasoconstriction, insulin secretion. Beta-adrenergic receptors. 1. HR/contractility, lipolysis, renin secretion. 2. Vasodilation, bronchodilation, glycogenolysis. 3. Lipolysis, brown fat thermogenesis. Pheochromocytoma catecholamine physiology/pathophysiology. Clinical presentation. Epidemiology. Signs and symptoms. Diagnosis. Biochemical. Localization. Management. Preoperative. Operative. Postoperative. Pregnancy. Pheochromocytoma 0.01 to 0.1% of HDN population, M equals F. Found in 0.5% of those screened. M equals F. 3rd to 5th decades of life. Rare, investigate only if clinically suspicion. Signs or symptoms. Severe HDN, HDN crisis. Refractory HDN, greater than 3 drugs. HTN present at age less than 20 or greater than 50. Adrenal lesion found on imaging, X. Incidental oma, Pheo. Signs and symptoms: the 5 Ps, the classical triad, paroxysms. Pressure, HTN 90%. Pain, headache 80%. Perspiration 71%. Palpitation 64%. Pallor 42%. Paroxysms. The classical triad. Pain, headache, perspiration, palpitations. Lack of all 3 virtually excluded diagnosis of Pheo in a series of greater than 21,0000 patients. Pheo, paroxysms, spells. 10 to 60 minutes duration. Frequency, daily to monthly. Spontaneous. Precipitated. Diagnostic procedures, IA contrast, IV is okay. Drugs, opioids, unopposed blockade, anesthesia induction, histamine, ACT, glucagon, metoclopramide. Strenuous exercise, movement that increases intra-abdo pressure, lifting, straining. Micturition, bladder paraganglioma. Pheo, hypotension. Hypotension, orthostatic/paroxysmal, occurs in many patients. Mechanisms: ICF contraction, loss of postural reflexes due to prolonged catecholamine stimulation, tumor release of adrenomedullin, vasodilatory neuropeptide. Pheo, signs and symptoms: NV, abdo pain, severe constipation, megacolon. Chest pains, anxiety, angina/me with normal coronaries, catecholamine-induced myocardial oxygen consumption or coronary vasospasm. CHF. HTN hypertrophic cardiomyopathy, diastolic disc. Catechol-induced dilated cardiomyopathy, systolic disc. Cardiac dysrhythmia and conduction defects. Pheo, signs: metabolic, hypercalcemia, associated Men2-HPT, PTHRP secretion by Pheo, mild glucose intolerance, lipolysis, weight loss, ketosis greater than VLDL synthesis, TG. Pheo, rule of 10% extra adrenal, closer to 15%. 10% occur in children. 10% familial, closer to 20%. 10% bilateral or multiple, more if familial. 10% recur, more if extra-adrenal. 10% malignant. 10% discovered incidentally. Familial Pheo Men2A 50% Pheo, usually bilateral, MTC, HPT Men2B. 50% Pheo, usually bilateral, MTC, mucosal neuroma, marfanoid habitus. Von Hippel-Lindau. 50% Pheo, usually bilateral, retinoblastoma, cerebellar hemangioma, nephroma, renal/pancreas cysts. NF1, von Recklinghausen's. 2% Pheo, 50% if NF1 and HTN. Café au lait spots, neurofibroma, optic glaucoma. Familial paraganglioma. Familial Pheo and islet cell tumor. Other, tuberous sclerosis, Sturge-Weber, ataxia-telangiectasia, Carney's triad, Pheo, gastric leiomyoma, pulmonchondroma. Pheochromocytoma, catecholamine physiology/pathophysiology. Clinical presentation. Epidemiology. Signs and symptoms. Diagnosis. Biochemical. Localization. Management. Preoperative. Operative. Postoperative. Pregnancy. 24 hours urine collection. 24 hours urine collection. Creatinine, catecholamines, metanephrines, vanillamandelic acid, VMA, plus/dopamine. HPLC with electrochemical detection or mass spect. Positive results, greater than 2 to 3-fold elevation. 24 hours archetypals greater than 2-fold elevation. ULN for total catechals 591 to 819 mol/d. 24 hours U total metanephrines greater than 1.2 micrograms/d, 6.5 micromoles/d. 24 hours UVMA greater than 3-fold elevation. ULN 35 micromoles/d for most assays. 24 hours urine collection test characteristics. 24 hours archetypals SEN 83%, SPEC 88%. 24 hours U total metanephrines SEN 76%, SPEC 94%. 24 hours archetypals plus U total metanephrines SEN 90%, SPEC 98%. 24 hours UVMA SEN 63%, SPEC 94%. Sensitivity increased if 24 hours urine collection begun at onset of a paroxysm. 24 hours urine, false positive. Drugs, TCAs, MAOI, levodopa, methyldopa, labetalol, propanolol, clonidine, withdrawal, illicit drugs, opioids, amphetamines, cocaine, ethanol, sympathomimetics, cold remedies. Hold these medications for 2 weeks. Major physical stress, hypoglycemia, stroke, raised ICP, etc. OSA. Plasma catecholamines. Drawn with patient fasting, supine, with an indwelling catheter in place greater than 30 minutes. Plasma total catechals greater than 11.8 nm, 2000 pg per milliliter. SEN 85%, SPEC 80%. False positives, same as for 24 hours urine testing, also with dietetics, smoking. CRF and ESRD. Oliguric to anuric 24 hours urines inaccurate. Plasma epinephrine best test for Pheo in ESRD. Plasminopy and metanephrines falsely elevated in ESRD. Plasma metanephrines not postural dependent, can draw normally. Secreted continuously by Pheo. SEN 99%, SPEC 89%. False positive, acetaminophen. Biochemical tests, summary. SEN. SPEC. Archetypals. 83%. 88%. U total metanephrines. 76%. 94%. Archetypals plus metaneph. 90%. 98%. UVMA. 63%. Plasma catecholamines. 85%. 80%. Plasma metanephrines. 99%. 89%. Suppression/stimulation testing. Clonidine suppression may precipitate hypertensive shock. Unlike normals, Pheo patients won't suppress their plasminopy with clonidine. Glucagon stimulation may precipitate hypertensive crisis. Pheo patients, but not normals, will have a greater than 3x increase in plasminopy with glucagon. Localization, imaging. CT abdomen. Adrenal Pheo SEN 93 to 100%. Extra-adrenal Pheo SEN 90%. MRI. Greater than SEN than CT for extra-adrenal Pheo. Localization, imaging. CT abdomen. Adrenal Pheo SEN 93 to 100%. Extra-adrenal Pheo SEN 90%. MRI. Greater than SEN than CT for extra-adrenal Pheo. MIG scan. SEN 77 to 90%, SPEC 95 to 100%. MIG scan 123I or 131I labeled meta-adobenzylguanidine. MIG catecholamine precursor taken up by the tumor. Inject MIG, scan at 24 hours, 48 hours, 72 hours. Lugol's 1-GTT to Dex 90, from 2D prior until 7D after MIG injection to protect thyroid. False negative scan. Drugs: labetalol, risperidone, TCAs, phenothiazines. Must hold these medications for 4 to 6 weeks prior to scan. Localization: nuclear medicine. MIG. 111 indium pentriotide. Some feel have somatostatin receptors. PET. 18F-fluorodeoxyglucose, FDG. 6,18F-fluorodopamine. Pheochromocytoma catecholamine physiology/pathophysiology. Clinical presentation. Epidemiology. Signs and symptoms. Diagnosis. Biochemical. Localization. Management. Preoperative. Operative. Postoperative. Pregnancy. Pheo management. Prior to 1951, reported mortality for excision of pheochromocytoma 24 to 50%. HTN crisis, arrhythmia, ME, stroke. Hypertensive shock. Currently, mortality, 0 to 2.7%. Preoperative preparation, blockade. New anesthetic techniques. Anesthetic agents. Intraoperative monitoring, arterial line, EKG monitor, CVP line, Swan guns. Experienced and coordinated team. Endocrinologist, anesthesiologist, and surgeon. Pre-op W/up CBC, lights, creatinine, INR/PTTCXR EKG. Echo, RO dilated CMY 2 degrees catechals, pre-op preparation regimens. Combine plus blockade. Phenoxybenzamine. Selective 1 blocker, X. Prazosin. Propanolol. Metyrosine. Calcium channel blocker, CCB. Nicardipine. Pre-op plus blockade start at least 10-14 D pre-op phenoxybenzamine. Allow sufficient time for free expansion. Phenoxybenzamine. Special pharmacy access only, no DIN. Drug of choice. Covalently binds receptors, 1 greater than 2. Start 10 mg per bid, increase Q2D by 10 to 20 mg/d. Increase until BP control and no more paroxysms. Maintenance 40 to 80 mg/d, some need more than 200 mg/d. Salt load, NaCl 600 mg odd to des tolerated. Pre-op plus blockade phenoxybenzamine, countered, selective 1 blockers. Side effect, orthostasis with dosage required to normalized seated BP, reflexed tachycardia. Drawback, periop hypotension/shock unlikely to respond to pressor agent. Selective 1 blockers. Prazosin, terazosin, doxazosin. Some experience with prazosin for pheo pre-op prep. Not routinely used as incomplete blockade. Less orthostasis and reflex tachycardia than phenoxybenzamine. Used more for long-term RX, inoperable or malignant pheo, pre-op, plus blockade. Used to control reflex tachycardia and prophylaxis against arrhythmia during surgery. Start only after effective blockade, may PPT-HTN. If suspect CHF/dilated CMY, start low dose. Propanolol most studied in pheo prep. Start 10 mg per bid, increase to control HR. Pre-op plus blockade if BP still not controlled despite plus blockade. Add prazosin to phenoxybenzamine. Add CCB, ACE-I. Avoid diuretics as already if contracted. Metyrosine. Pre-op plus blockade meds given on AM of surgery period HTN. 4-phentylamine. Short-acting non-selective blocker. Test dose 1 mg, then 2 to 5 mg for Q1 2 hours PRN or as continuous infusion, 100 mg in 500 cc D5W, titrate to BP. 4-nitroprusside, NTP. Periop arrhythmia, 4-esmolol. Periop hypotension, 4-crystalloid plus / colloid. Pheo, Rx of HTN crisis 4-phentylamine 4-NTP 4-esmolol. 4-labetalol, combined plus blocker. Preop, metyrosine synthetic inhibitor of tyrosine hydroxylase, TH. L-dopa. Dopamine. Synthetic inhibitor of tyrosine hydroxylase, TH. Special Pharm access, no thin. Start 250 mg max 1 gram ct. Severe SEs, sedation, extrapyramidal, diarrhea, nausea/vomit, anxiety, renal/cholesteatones, galactria. Alone may insufficiently control BP and reported HTN crises during Pheo operation. Restrict use to inoperable/malignant Pheo or as adjunct to plus blockade or other pre-op prep. DBH. Norepinephrine. PNMD. Epinephrine. Pre-op, CCB nicardipine, most commonly used agent. Block NOP-mediated CA transport into vascular smooth muscle. Nicardipine, most commonly used agent. Nicardipine, France study. Started po 24 hours to few weeks pre-op to control BP and allow ICF restoration. After intubation for nicardipine GTT, start 2.5 micrograms/kg per minute. For nicardipine adjusted to SPP. Stopped prior to ligation of tumor venous drainage. Tachycardia Rx with concurrent 4-esmolol. Advantage: periop hypotension may still respond to pressor agents as opposed to those patients who are completely blocked, or admit night before for overnight for saline. Arterial line, EKG monitor, CVP line. Non-CHF, consider Swan-Ganz. Regardless of pre-op medications. Have ready, 4-phentylamine, 4-NTP, 4-esmolol. Rx hypotension with crystalloid plus / colloid first. Aim for CVP 12 or wedge 15. Inotropes may not work. OR anesthetic choice, laparoscopic adrenalectomy if tumor less than 8 cm. Influrane or isoflurane, don't sensitized myocardium to catecholamines. Halothane, may sensitize heart arrhythmia. Laparoscopic adrenalectomy if tumor less than 8 cm. Post-op most cases can stop all BP meds post-op. Post-op hypotension, 4-crystalloid. HTN free, 5 years 74%, 10 years 45%. 24 hours urine collection 2 weeks post-op. Surveillance. 24 hours urine collections Q1Y for at least 10 years. Lifelong F/up. Pheo, unresectable, malignant. Blockade. Selective 1 blockers, prazosin, terazosin, doxazosin, first line as less side effects. Phenoxybenzamine, more complete blockade. Blocker. CCB, ACE-I, etc. Nuclear medicine Rx. High dose 131 imib or 111 indium octreotide depending on MIB scan or octreoscan pickup. Sensitize tumor with carboplatin plus 5-FU.